Okay, do I really need a microphone for this? Or it's okay? But anyway, I was tasked to talk about the safety about the big league, being the big league. I don't know what Rushali wanted me to talk about, but certainly it's about safety. And since we started up with a pre-operative, with a pre-conference workshop, talking about safety. I'm going to end it again with safety right here. So what I want to talk, I don't have anything to disclose right now, but what we want to do is to work together for safe care for every child everywhere. This is what I think this conference is all about, right? So that's why we are all getting together. So how can we develop the future generations of health professionals to provide safe and child-centered care in partnership with children and families? What we can do actually is to make sure that we are trying to eliminate this serious harm across all hospitals that take care of children by working together. So when we work together, what do we want to achieve? We want to achieve a reduction in hospital-acquired infections. We want to achieve a reduction in the percentage of readmission. And we also want to achieve a reduction in the percentage of serious safety events. And in doing that, I'd like to make this discussion be going around priorities and urgencies for pediatric safety. I'd like to talk about vulnerability in the hospital setting for the child. I'd like to talk about the significance of tracking pediatric harm. So why do we have to focus on children? We have to focus on them because they are not little adults. I think we all know that as pediatric anesthesiologists. And it is true in medicine, certainly, that the impact on the vulnerability of children to medical error and harm resulting from care is really a lot. So we really have to focus on children. We have to separate this population from the usual adult population. Another thing is that there are 4 unique considerations for patient safety in pediatric anesthesia. First is that children go through different physiological changes. Second, drug dosing is weight dependent. We know that very well, and we know that many errors have come off because of this. And children have different diseases, and that they cannot do anything without adults helping them out, right? They won't be able to tell us anything without the adults who accompany them, helping them. And certainly we have to go back to the challenge, primum non nocere, which means that do no harm. I think this has been the overall theme of this conference. And when we talk about patient care, we also talk about pediatric patient care becoming safe, timely, effective, efficient, equitable, and certainly pediatric patient-centered. It has to be all about the pediatric patient. There was a study that was done wherein they took out the problems of the children, and this was done by the National Patient Safety Agency. When they did this, they found certain things like medication errors, poor integrated care, falling between the cracks, a lack in communication, and certainly some human factor issues. So what are some vulnerabilities for pediatric patients? It's about central line associated bloodstream infections and of course adverse drug events, which certainly there has been a lot of that in a lot of hospitals as well. So when we talk about the future, in just 2 words, we need to talk about transparency. We need to be able to talk about the things we do, about the things we see, and how we manage our patients. So in order to learn from each other, and of course after that, we need to be able to have a process that is not only reliable, that has to be implemented and has to be able to ensure that we will certainly reduce harm. So what should we do? First, we define the measures that matter. Second, we measure our performance. Third, we utilize the results of these measurements. And when we do that, we make sure that the patients with needs until we follow them until their needs have been met. So I'd like to give you an example of my institution. I hail from the Philippines. I belong to a hospital that has 550 beds and certainly a number of patients in the emergency room that leads up to about 100,000 a year. So in our journey, I'd like to show you what is in our current safety package. We have incident reporting. we make sure that everybody reports an incident. We try to maintain a non-punitive environment. We make sure that we talk about all our HAIs. We also make sure that MNMs, our mortality and morbidities, are talked about. We use our S-bar, which means that we talk about it in a manner wherein we come up with recommendations in the end so that we will improve whatever we have done. Unplanned readmissions, we talk about a culture change as well. So in our institution, upon entry, how do we ensure safety? We have 3 identifiers: patient's name, birth date, and their identification number. That's very important for patient safety. And in every encounter, we make sure that the standard, this is a standard. Always 2 identifiers have to be present and have to be asked before every transaction. And as we go live, we have gone live, we have computerized our system. We are also ensuring that the process of patient identification is enhanced in this system. In the emergency room, we have also identified some things like risks, because the environment is hectic, it's very highly emotional, it's very unpredictable. The monitors, we use vital signs parameters, but there is no forcing functions in all of this. There are always alerts, and people, because of so many patients, there becomes alert fatigue. So another thing is that we find out what are the pediatric specific risks. We need to find out what is normal. We need to maintain competencies in pediatric patients, in taking care of pediatric patients. So what are the strategies we did? We actually made sure that we had teamwork training, wherein we had mutual support and task assistance. We assessed the devices. We made sure that we had a health assessment tool that would check the checklist, the guidelines. We made use of evidence-based guidelines. And based on the Institute of Medicine, it says that you have to identify a pediatric subject matter expert who will ensure that there is ongoing training. We have CME, and we have the equipment needs that we have to have for our taking care of our patients. And of course, with 80,000 visits a year and about 18,000 which are pediatrics, they are all lumped in with adults, and we found out that there are certainly challenges to this model. We had to see that there was equipment, medication, and of course we had to switch gears when you're in the emergency room, because you have a population of 1 to 100, so you had to shift gears if you were an emergency room physician. So we had to make sure that we also found out, the training, we had a lot of inexperienced nurses, and every time the countries outside of us opened for employment, all our nurses go out. So we have had incidences where we had 20 nurses leaving in 1 month. So what did we do to address this? How did we identify harm and potential harm? How do we prevent incidents once we identify a problem? Actually, we separated our adult and pediatric emergency rooms because we found out we had so many patients already. We ensured that we had the best practice guidelines. We started training our people. We had regular training. We had monthly training. We had a quality improvement process. At the moment, we have radio frequency devices. We have recognition cameras that ensures that we have timely delivery of service. So we also created this environment wherein these children were not already afraid. We made sure that all our what surrounds them is like a playroom. We made sure that no trash cans were on the floor, which they could just move out and touch. We made sure that everything was as safe as possible. So when we went to the admission, as we go on through our journey, what do we have in admission? We had to think about improving medication safety. We are now in the process of going through the EMR, so we are going towards computerized physician order entry for pediatric dosing, which will be a help in reducing errors. Because we have found out that most of these errors are administration errors, because most pediatric doses still require math to convert. There was a lack of standard formulation. So right now in the units, we have cows, what we call cows, or the computer on wheels with barcode scanning, so they can actually determine that medications are given to the child. And then we have our strategies on patient medication, standardization, pre-calculated dose, barcode medication, and including our clinical pharmacist. Of course, effective communication, as I said in the workshop, is very effective. Clinical, we make sure the results are told to them right away. Our handover processes, we go back to old times wherein they are bedside endorsements. We don't just allow them to stay in the nurses' stations. They discuss it in front of the patient, involve the patient. We have good departmental handover. We make sure that all these handovers are done consistently in the entire hospital. And of course, during surgery, what do we want for a patient? We have to focus on all of this. As you saw, we need to have surgical teams that include us. We cannot not be in multidisciplinary team conferences. We have to be there together. We have to maintain our competency. We have to make sure that we are all specialists. We made sure we had good site marking. We made sure that we did the timeout process. Once the patient is covered, the orange towel is put on top of it, and nobody moves until the timeout is conducted. Once it is conducted, the orange towel is given to the anesthesiologist, then they can start cutting. So we ensure that everything is in order. We have mortality rates, which we monitor. We get data from our system. We monitor newborn mortality rate, and we have improved over the years. We have improved by seeing what we have, what has caused all these red marks, wherein we have failed in 2012, 2013, and improved. That's why we have come in such a way that we have reached the benchmark that we wanted to achieve. In fact, even in terms of exclusive breastfeeding, we are monitoring this and making sure that everything is going well. And in the end, it's all about infection control. What is it all about? It's always as simple as washing your hands. We have found that when we have tracked our hand washing, again through badges that have radio frequency devices, we have found at least an improvement in hand washing. It's very difficult to let people wash their hands. They keep forgetting to wash their hands. But we have certainly seen a decline in our infections. What do we want to do with harm? We want it to disappear. We want to ensure that it is harm-free. This was taken from a pediatric international community that talks about quality and safety. There is a pediatric safety thermometer that we can follow. We can see if it goes up or down in terms, as long as we can measure all these instances, then we can help each other. We want to make it safer together. So therefore, it's not about only quality improvement, which is raising the ceiling. It's about patient safety, wherein we also raise the floor and make sure that every time we raise the floor, we just keep on raising the bar and making sure that everything is in order for our kids. And like I said during the workshop, collaboration and commitment is very important because we have to all work together. As you are all working together right now, you're all coming together to ensure that our children are safe. We have to make a commitment to measuring this safety performance. We have to make sure that we have to pursue these improvement targets to make sure that we get to where we want to go. And then we have to share our resources. So we can do this all over again. We can do this next time around. I'd like to end with a story. There was a man, an old man, with an asset of 17 ducks. He had 3 sons. When he passed away, he had a will. He said in his will, I leave half of the 17 ducks to my first son. I leave a third to my second son, and I leave 1/9 to my third son. Of course, they couldn't divide 17 by a half. They couldn't divide it by a third nor a 9th. So they were fighting. So they went to a wise man now who said, and they told him their problem. The wise man decided to said, okay, why don't I add 1 more duck so it becomes 18? So half of it is 9, 1/3 of it is 6, and 1/9 of it is 2, right? So that's 9 plus 6 is 15 plus 2 is 17. So that leaves 1 more duck. So he gets back the duck, right? So what's the moral of the story? The moral of the story is that when there is a problem, we have to look for the 18th duck. And the 18th duck is the common ground. The common ground wherein we can all come together. So this is what we're doing. We're trying to find a solution, but we still have to ensure that we believe there is a solution, and that is the way to move forward. Thank you.
Thank you, Erlinda, for that enlightening talk.